Hello and welcome to the Pain Options Education channel. I'm Darren.
And I'm definitely Tim.
Good to hear. We're continuing our series, the pelvis series today, and we're talking about pain, pelvic girdle pain. It's a sensitivity disorder. And I'll go straight, well, I'm not going straight to the slide I thought I was, but this is a reminder of the other editions in our series. So you can look back at the problem with the pelvis, understanding different paradigms of the pelvis, assessment, actually assessing the pelvis, but today we're up to sensitivity. Where I did think I was going back to this, Tim, your favourite slide again. And I guess it's probably clear by this point in time that we don't care too much for the movement and positional fault paradigms, or care is not the right word, but we just don't trust the validity of them.
I think that's pretty well established. So we moved on from that quite a period of time ago now. Movement of other structures around there and assessment of other structures around the region and how people move and function themselves.
Yes, that's massively important, but we're talking movement within the pelvis.
Yeah, exactly.
Not so important.
Yeah.
Okay, good. So first here, we've got this heading, sensitivity of the pelvis. And it really is good to kind of think about this study, or series of studies, and I think it was actually his PhD that Valdi here has done.
Yeah.
And in the past, people have thought of the active straight leg raise test as a test where you lift the leg, and when that's heavy or painful, that denotes some kind of instability in the pelvis. RSA studies subsequently during that very test have shown that that is not the case. There is no instability there. But I think what Valdi's done is very interesting. So he's taken pain-free people without pain and injected their long dorsal ligament around the PSIS there with hypertonic saline to sensitize the ligament. And in these two studies quoted here, in the first he looked at pain provocation tests. So he tested them out, they were normal. Then he injected the ligament, redid the pain provocation test, and they went from negative to positive. So that fits because the hypertonic saline is sensitizing the ligament, so that makes total sense. But at the same time, he did the active straight leg raise, and again, people scored very lowly on that, 0 to 1, which is basically normal on a 5-point scale.
Of pain, you mean?
No, heaviness of the leg.
Heaviness,
yes. And then once he's injected them, those scores went from insignificant to positive as well. So clearly that change in the active straight leg raise is mediated by sensitivity, nothing to do with movement within the pelvis itself, because injecting hypertonic saline into pelvic ligaments does not increase the mobility of the pelvis.
Okay.
Yeah.
So I think that fits with what we're describing around these tests that provoke that region are doing so because in this instance the sacroiliac joint is sensitive.
Yep.
So could we say that those tests are helpful in provoking symptoms and saying, yes, the source of that sensitivity is the sacroiliac joint, but it doesn't tell us why it's sensitive or what's driving it?
Yeah, exactly. It doesn't really tell us why.
Yep.
But I think just in terms of, trying to move from this paradigm of movement and positional faults,
Yep.
looking for a much more plausible explanation of what's going on in the pelvis, more aligned to contemporary pain science, really. Yep. This couple of studies by Valdi are really positive in that regard.
Sure.
Any other thoughts on sensitivity in general?
Not with that.
Or specifically,
topic.
You should say,
Yeah.
yes. So yes, really there we're talking about specific sensitivity of the pelvic structures around the sacroiliac joint. So here we're talking a bit more about sensitivity in pregnancy. Did you have anything you wanted to say about this firstly?
Well, as we've said, the prevalence is perhaps somewhat higher in terms of sacroiliac joint pain in pregnant women compared to general population. Is that fair to say?
Yes.
And then traditionally we have thought, as we've talked previously, that that's to do with stability issues around the sacroiliac joint, but that's been shown to not necessarily be the case. And then we've also talked a bit around, well, arguably the joint becomes sensitive, which is why the tests are positive, but why more sensitive in pregnancy than at other times?
Yeah, and we did talk about hormones a little bit, and it probably does come back to that in a way.
Yeah.
One of the studies I've been involved with Valdi, indeed, we looked at pain sensitivity during pregnancy, or we had three groups really. One group of non-pregnant women who had never had children, and then two groups, one with kind of more mild pain and one with more severe, moderate to severe pain. And what we found there is that between the levels of pain, there was no difference. But those, whether they had low level pain or high level pain, those people were more sensitive than the non-pregnant women. And it wasn't necessarily localized to the pelvis either, it was a bit more widespread. So it seems like during pregnancy, women become more sensitive to pain as part of the pregnancy. And then that would kind of then maybe set them up for other things to, escalate that and a pain disorder to kind of emerge.
But if they're more widely sensitive, how come they present with pain that's just at the sacroiliac joint at times?
Yeah, well, it could be to do with loading and other factors around that.
So that's the interesting concept, isn't it, around that different factors that contribute. Obviously, the mechanics of the body changes as you become more heavily pregnant, so both posture side of things and I guess the length-tension relationships on certain muscles around the region also associated with that. But again, that's only another small part of those, I guess, factors across different domains that may result in the system becoming sensitive.
It's a tipping point issue, isn't it? Like, what's enough to cause a tipping point where something's potentially sensitive but not pain-provoking to then becoming pain-provoking, and it might be little things that add together to get you to that point.
And this is often brought up as a question when I discuss this topic, is around, well, it's still mechanical pain at times that these pregnant women are presenting with, and it might be only one-sided, so there's clearly a structure there. So again, how does this work? But you could mount a story that, for example, we've talked about hormonal changes pre-sensitized tissues, and things that are normally sub-threshold become above the threshold to trigger pain. So they may have a physical incident such as a bend or a lift or a squat or a step or something where their pain comes on, or there may not. But then that's where you dig further into their story around how's their other general health factors, their level of exercise, their sleep, their mood, etc. And you might then see a combination of those together that could be enough to explain, hang on, this is pre-sensitized, and then there is this mechanical element to it where that joint becomes sensitive.
Yep, totally agree with all that. And it does remind me of it makes me think of the mechanical versus non-mechanical presentations here. And you've mentioned the mechanical side there, but then also there's these women during pregnancy that do present that just seem very non-mechanical in nature. These are the kind of ones that, they can't walk. They might be on crutches or in a wheelchair, and it's very non-mechanical, highly sensitized, seems almost very inflammatory in nature. So that's the other end of the spectrum, really.
So that could be with a true sacroiliitis, for example, or it could also be with a broader non-specific sensitivity that's not just to that joint, perhaps.
Yep, and tougher to manage during pregnancy often.
Sure.
Okay, good. And then we wanted to talk just a bit more about pain sensitivity in general.
Yeah.
What do you got on this one?
Well, we can see this anywhere in the body where some people have elevated levels of pain sensitivity, and again, that could be for a number of reasons of different factors. Some people are prone to that, if you like. We know that in normal populations, people have heightened levels of sensitivity or responsiveness to tests. Or you may have people that aren't normally that sensitive, but again, a number of factors might combine to make their system more sensitive. And some of those people may not necessarily have localized sacroiliac joint pain, but they might have more widespread pain in the region. So that might be an example of that. But some of them do have localized pain in their sacroiliac joint, but maybe broader sensitivity down their leg that doesn't fit from, for example, a pathology in the joint, but there is that broad sensitivity through the area. So there's some of the ones I think that they don't fit that mechanical picture. There's not exactly something inflammatory going on, but they're in a lot of pain through that region. And again, I think putting the story together as well as the physical examination can help identify those ones.
Yeah, exactly what I was thinking as you were saying that. Like if someone comes in, they point to their sacroiliac joint and you think, okay, they've got pain there, and all you do is assess the pelvis and you find some positive tests, well, you'll get the same in both of those scenarios. So you need to step back, look at the whole person and see, is it an isolated problem within the pelvis or is it something bigger?
And we talked about that earlier under the subjective examination of looking at the behaviour of their symptoms, so you get a clearer pattern, and doing that well first, because it might be everything hurts all of the time and there are broader sensitivity issues, and they might even say things like, yeah, when I'm really tired or when I'm more stressed, my pain's also worse. It's not just with loading the leg. In that instance, then you know early on, right, I'm going to have to look for pain sensitivity as part of my physical examination, as opposed to someone who just describes more mechanical type symptoms with clear aggravating and easing factors.
Yeah, I think we've got a lot more to share on pain sensitivity, and you'll probably catch that in one of our upcoming series, I would imagine.
Yep.
Out of place. So the person comes in, they believe they've got a pelvis that's out of place, but more than that, they actually can feel that it's out of place. That's what they'll report to you. And I felt the same thing in my thoracic spine. I was like, oh, it feels out of place to me, but I know it's not. So, what's going on with these people? And
well, they're the ones I refer to you, I think, Darren.
Oh, thanks, Tim. Well, it is an interesting dilemma, and we'll probably touch on it a bit more around management, because it's a clear thing that you're going to have to manage, if it's an issue. But really, here I just wanted to talk about, well, what's a plausible alternate hypothesis for these people in terms of their pelvis not being out, but it does feel like that. And
because they will come in and they'll say, I can feel it's different, I can feel a lump there, it's bigger, or I know there's more when I'm leaning on a chair, I can feel it's poking out more, for example.
Yeah, so let's kind of think about why that might be. In a couple of cohorts, we have used Ben Wan's free back questionnaire, which looks at body perception, and found that women during pregnancy with higher levels of pain do score more poorly on that, or show higher levels of change in body perception. Yeah. So that could clearly be something in this, where they're just perceiving that area differently. I mean, that's related to work around the representation of the body in the brain and all that kind of stuff. But there might be something in that, in redistribution of perception of the body. So that could be one thing. It might be that everybody has little asymmetries, but you don't really know until it's painful, and that's when you're touching it and you're feeling it and your attention's drawn to it, then it becomes an issue. Yeah. Any other thoughts?
Well, they're the two main ones, and my sense is people obviously are in pain, they're worried about it, they don't really understand what's wrong, and particularly if they're worried that it's out of place, they'll tend to have additional focus on that area, so that heightened awareness can make the area more sensitive, so they get more information in, and again the perceptual side of that becomes relevant. People often talk about it swelling and feeling bigger as well, but I've had many people say that, but when I'm looking at it, I've never seen one that's swollen, if you know what I mean, without trauma on the area, obviously.
Yeah, and that fits exactly in Ben Wan's work, where he's validated that. Well, that perception questionnaire was brought out of the work where they got people to draw their backs, and they draw one side bigger than the other, because that's what they see within themselves.
And we've done a little bit of work around that about body scanning, where you're trying to visualise the shape or the size of a limb, for example, and many people report that it feels bigger, or they can picture it as seeing it bigger, but then when you get them to open their eyes, they'll agree that it's not bigger. But not always. Some people will visually tell you, no, I can see it's bigger, even if you get a tape measure out and show them around their knees, for example, that the size is the same. So it seems predominantly a perceptual type issue, but it's something you have to validate and you cannot dismiss with these people.
Yeah, exactly. You took the words out of my mouth. You have to potentially address this, or validate it, or give them some other plausible explanation. But yeah, I think we'll touch more on management around this, but it's an important consideration. But there are alternatives in neurophysiological.
That'll be the phone now.
That'll
We'll get that later.
Yes.
Yeah.
There are other neurophysiological mechanisms by which people could feel this kind of sensation of their joint being out of place, as to opposed to the research around it actually being out of place is pretty poor.
Yeah.
Great.
Good.
We've got time for one more question, Tim, if you've got any more questions.
Well, I don't, but someone else might, Darren.
Well, then they could email us on education@painoptions.com.au, and I know Tim is checking that every night to look for your questions, so we'll get back to you.
Send us your questions.
Indeed. And this is just a reminder of what's coming up in this series, and I mentioned management a couple of times, so management is the next topic. Good. Bye for now.